Welcome everybody to Staffordshire Health and Wellbeing Board this afternoon. I'm Dr. Alison Bradley and I'm the Clinical Chair of North Staffordshire CCG and Co-Chair of the Health and Wellbeing Board. So first of all, turn to apologies, and we've had apologies from Julia Jessel, Johnny McMahon, Paddy Hannigan, Rita Heseltine, Roger Lees, Jude Russell, Wendy Thompson and Philip White. The meeting's going to be a hybrid meeting with a number of colleagues actually in the council chambers here in Stafford, but there are also some colleagues that are joining on Microsoft Teams. So it baffles me, this technology, but I'm sure somebody's in charge. Okay, so if we turn to declarations of interest, does anybody have any declarations of interest pertaining to the items on the agenda? No. Okay, thank you. So if we could now turn to the minutes of the last meeting that were held on the 3rd of June. And I will do a page turn, and if I could just start, so if colleagues could if raise their hands or indicate if there's anything that on that page that they feel needs correcting. And I'd like to start with page 1. It's just really a comment, and that I've noticed that the only members that are down as attending are I think people who were actually in the council chambers, and there are a number of colleagues, including myself, who joined on Teams, which need to be added, please. Okay, so anything on page 1?
Yeah, I did mention it when I came in. I'm not actually on as attending at all, and I was here in person last time. But I've had a quick look at the membership, and I don't appear to be on there either. But I'm getting sent all the invitations to attend the meetings.
Okay, thank you. So can we update the list? Thank you. Okay. So page 2, page 3, page 4. Page 5, page 6, and page 7. Okay, thank you. So I will sign to say that they're a true reflection of the meeting on the 3rd of June. Thank you. We haven't received any questions from the public. So I'll now move into the agenda, and for the benefit of members of the public who are watching the meeting, could I ask that colleagues introduce themselves before they present? So if I could first of all turn to Richard to give us an update, a COVID update.
Thank you, Chair. So there is quite a lot of COVID around at the moment. The case rate is around 350 per 100,000 in the last 7 days, and that's been creeping up slowly over the last few weeks. The number of hospitalisations is relatively low, certainly a lot lower than it was in January and February this year at the peak of the second wave. However, that is also creeping up, and the NHS and social care are facing quite considerable pressure at the moment from a combination of COVID-related and non-COVID-related illness. So I think it remains important for the public just to be aware that the virus is still out there and does still pose a threat, and to take sensible precautions to prevent the spread of infection. That means keeping a distance from one another where you can, wearing face coverings in crowded indoor places, and making sure you maintain good hand hygiene wherever possible. That, I think, is all to say at the moment, Chair. Obviously, there's a bit more detail about COVID in the next agenda item. Thank you.
Thank you, Richard. Are there any questions for Richard? Okay, thank you. So we can move on to the next agenda item, which is for Richard again, which is the annual report of the Director of Public Health.
Thank you, Chair. So there is a presentation on screen which I will talk to in a moment. Just by way of a bit of background, one of my responsibilities is to produce an annual report. The last one we did was on use of technology. That was actually 2 years ago. For reasons that I think are obvious, we didn't get a chance to do one last year. This year's annual report will be on the COVID-19 pandemic. What I'm going to try and do today is just trail some of the initial findings and get any initial reactions from the Health and Wellbeing Board, and then we anticipate publishing the full report during the autumn. So the slides are up on screen. John, if you could go to the first one, please. So I'm going to start just by examining the cumulative impact of the pandemic. The direct impact, things like cases and hospitalizations and deaths, has been the most obvious. So that shows the epidemic curve. So far in Staffordshire, we've had just under 75,000 cases, and that's a cumulative case rate, in other words, a case rate since the start of the pandemic of about 8,500 cases per 100,000 population. There is an issue here with counting, so you can see that the first wave was probably vastly under-enumerated, and that's because at that time the country did not have well-developed diagnostic laboratory facilities. So probably something like 1 in 10, 1 in 20 cases was actually confirmed. During the second wave, last winter, and the third wave at the moment, laboratory capacity is much greater, and we are counting a much higher proportion of cases, but there will still be a considerable number that are undiagnosed because people are relatively asymptomatic. So the cases that we know about are probably only a tip of the iceberg of all the cases that are out there. We go to the next one, John. Next slide picks up deaths. Again, you can see that during the first wave in March, April 2020, there was quite a considerable spike of deaths. There are 3 ways that deaths get counted. The first one is deaths within 28 days of a COVID diagnosis. The second one is deaths where COVID's been recorded on the death certificate. Both of those do have problems in that they first of all rely on COVID being diagnosed, and as I said, during the first wave there was quite a lot of underdiagnosis. On the other hand, they may overestimate the impact of the pandemic because some people will die with COVID rather than of COVID. So the metric we tend to look at is the excess number of deaths compared to the average for the pre-pandemic period. And on that score, there's been about 1,900 excess deaths during the pandemic period so far. The majority of those took place in the first and second waves. And at the moment, the death rate is about the same as it was during the previous 5 years. So at the moment, we are not seeing an excess of deaths, which is largely due to the impact of the vaccination programme. Next slide, please. We've done a little bit in the report to try and look at the variation in COVID across the county. So the first thing we've looked at is geography. All of these figures are now cumulative case rates. You can see from the shading on the Staffordshire map that there are some areas, and these are enumerated at ward level, that have had a much higher cumulative case rate than average. On the whole, they tend to correlate with areas of deprivation, not exclusively, but they tend to fit with those wards that where we know we have people who are less well off, living in densely crowded households, which does fit with what we know about how the virus transmits from person to person. The variation by age group is interesting, so we can see a relatively large case rate in the 20 to 29-year-olds. That is probably real and reflects probably greater social networks that younger adults have. The case rate then falls off as we get into older adult age groups, which again may reflect a degree of shielding that some of those people had, particularly during the first and second waves. It is then very high in 80-plus-year-olds. That probably reflects a very high testing rate in older adults, and that will be both because if they catch the infection, they're likely to have symptomatic disease and therefore get tested, and also because some people who are aged 80 plus live in care homes and have been tested regularly throughout So we tend to detect much higher proportion of cases in that age group. We go to the next one. The top left graph there shows variation by deprivation. You can see that there is a general trend for people in more deprived areas to have a higher case rate. That might be because they're more likely to get tested. I think that's unlikely. On the whole, people in deprived areas have lower access to healthcare, both diagnostic and treatment. So probably the converse is true, and that is actually a real trend for higher number of cases in deprived areas. And probably the trend is even more marked than it might appear on that graph. The other bit of variation is by ethnicity. Again, black and Asian minority ethnic groups seem to have a higher cumulative case rate than white ethnic groups. A little bit difficult to draw clear conclusions because that other group does have such a high case rate, so we are missing quite a lot of data there, which makes it difficult to be very confident about that finding. Now, it is really important to remember that as well as the direct impact of COVID, that is the infections, the hospitalizations and deaths, the pandemic has also had a wider impact. And that is due to the impact of the virus, but also due to the impact of control measures. Prolonged isolation, we know now, is very bad for people. So we do know that we've had a rise in mental health problems during the pandemic period, and that's been especially marked in children and young people. We're pretty confident there's been a rise in obesity because people have been sedentary during prolonged periods of lockdown. We know that children have had delays to education, which they are going to have to catch up at some point. We did see an increase in unemployment during the pandemic period. That does appear to be bouncing back now, so we're just waiting for the latest data points to tell us to what extent that's recovered. We know that the NHS routine business has been very severely impacted, so that we are now facing some quite considerable waiting lists for routine hospital treatments, and also some concerns about GP access. And care homes are another sector that have been particularly severely affected. So residents' quality of life has been affected by infection prevention and control measures, isolation, cohorting, and care homes have also faced increased costs and have had existing staff shortages exacerbated. The next couple of slides just present some headlines about the Staffordshire COVID response. I think on the whole we are very proud of our response in the county and that we have done pretty well under very challenging circumstances. A few headlines, so we've done about 2.3 million lateral flow device tests. We have contact traced 67,000 cases, and there is a typo there, it should be about 160,000 close contacts. We've managed 5,000 incidents, that is outbreaks of COVID in a range of settings, including schools, care homes and businesses. The districts and boroughs have managed about 10,000 applications for financial support, which has provided hardship payments for about 4,000 people. The police have issued 500 residents with fixed penalty notices, and we've issued 3 businesses with directions to curtail or limit their activities because of the threat to public health. I think those metrics are important because of the low numbers, not the high numbers. I think the approach of engage, explain, encourage and enforce only where necessary has really paid off in terms of building public support and trust. If we go to the next slide, we've distributed about 4.5 million items of personal protective equipment. The vaccination program has been a huge success. 1.3 million doses given so far, with 80% of adults now fully vaccinated. Particularly during the first wave, we distributed emergency food parcels to 3,500 people to provide them with essential sustenance. There have been 5,000 referrals to the voluntary sector for support, and the COVID hospital discharge pathways have dealt with about 25,000 discharges. About two-thirds of those went home compared to a target of 90%, so possibly a little bit more work to do in terms of always promoting independence. So some key themes that enabled that effective response. I think the first thing was some tremendous partnership working right across the public sector, but also harnessing the contribution of voluntary organisations, residents and the public. I think what I saw during the pandemic was a tremendous can-do attitude, people getting on with it and designing real solutions to real problems, and doing so with the minimum of governance and administration, really just doing what needed to be done when it needed to be done. I think our access to data has on the whole been very good. It has really catalysed our use of information dashboards so that we are now dealing with far more data in real time rather than retrospectively, and that's something I think we can build on in the future. I think our communication has been very good, and a real credit to the communications teams right across the public sector for that, making sure that the public had timely information on which to base their activities. And finally, use of technology. Again, the pandemic has been a catalyst for using technology, particularly to complement other means of care and support. So finally, some recommendations. So what you see there is just the draft. I'd be very interested in any reaction to those today. So first of all, and we will come on to this afternoon, we do need to refresh our joint strategic needs assessment and joint health and wellbeing strategy, just to pick up some of those longer term impacts from the pandemic, including the health inequalities that I alluded to earlier. I think that some economic and lifestyle related conditions, so things like diabetes, chronic heart disease, obesity, should feature prominently in our priorities, as indeed should mental health. We have an opportunity to strengthen those hospitals and hospital discharge pathways even more by ensuring they promote independence and get people home wherever possible. There has been a whole range of new relationships forged during the pandemic that I think we can build on, and that flexible and agile way of working that characterised a successful response, I think we can use as a blueprint of the way we work together in the future. The huge response we saw from the community to the pandemic, both in terms of the sacrifices that residents made during lockdown, but also people stepping forward to help the aged and the vulnerable. Again, I think we can build on that and try and make absolutely the best use of all those community assets out there and continue to develop that community capacity to offer support. And finally, to take advantage of that increased uptake of technology, particularly to promote new technologies wherever possible to provide and complement support for those who need it. I will stop there, Chair, and just invite any comments and questions. Thank you.
Thank you, Richard, for that really interesting presentation. So, has anybody got any questions or comments for Richard? No, and I can't see any hands coming up on Teams unless anybody tells me otherwise. Okay, thank you. So, so we've been asked to note the report and support the recommendations which were on the last slide, and noting that the full report will be circulated by the end of September. So, are we happy to support those recommendations and receive the report? Okay, thank you, and silence from Microsoft Teams, so we'll take that as accepted and supported. So thank you very much, Richard. Okay, so if we now move on to one of those items that was mentioned in Richard's report, and that's the joint strategic needs assessment, and Claire is going to present that to us. Yeah. Thank you, Claire.
Thank you. So on your agenda it may say Wendy Thompson. I'm actually presenting this item on her behalf. So I'm Claire McIver and I'm from Public Health at the County Council. So as Richard just mentioned, this is part of sort of the next stage in terms of thinking about the impact of COVID over the last 18 months, but also what else we know and sort of need to understand about the health and well-being of local population. You'll be aware that having a joint strategic needs assessment is a statutory responsibility for the board. what we felt would be particularly useful this time was to think about not just the needs and sort of the deficits and the things that we need to address in terms of how we improve health and well-being, but also to take a little bit of time to try and think about some of the assets and some of the sort of positive outcomes that we need to reflect on, and that would be a nice way to sort of capture some of the real positives over the last 18 months. Thanks, John. So today what I'll do is just give a really brief overview of the approach that's been taken so far in producing this year's JSNA. I'll give a quick overview of some of the key headlines, some of the sort of issues that are jumping out as perhaps potential priorities, as well as some of the assets and positive trends that we've observed. And then it will be hopefully an opportunity for members to give any feedback, open up for sort of brief discussion, comment on this as a working draft, and then to think about what needs to come next to produce that final output. So a strategic needs assessment, by its very nature, should be joint, so it should be something that's developed by the board as a collective. It should be owned by the board, and it should be then utilised to inform all of our sort of strategic direction, commissioning and activities across the system. It ideally will, as I say, bring together sort of anything that we need to know about people's health and well-being, their health needs, their care needs, and allow us to get a real good understanding of the population as a whole, not just populations who are accessing services, for example, but anything else we can incorporate. And it's about everything from sort of lifestyle issues all the way through to the wider determinants of health around people's sort of environments and the lives within which they live, and sort of make those decisions about their lifestyles. So the key components, just for your awareness in terms of how it's broken down this time. So there's a very high level needs and assets summary, which I will quickly go through today as part of this presentation. There's then a full annual sort of data update, which is the more detailed kind of granular level information, which will be shared with members following this meeting. And there will also be a year one sort of post-COVID, COVID-19 impact assessment. So that just gives a really in-depth review of what we know about COVID, and as Richard said, the sort of the collective and kind of overall impact, not just what we know in terms of cases and mortality and hospitalizations, but what we really think that means in terms of how that's affected our population. And again, that will be shared after this meeting with the board for you to sort of digest at your leisure, really, because it's a little bit more of a sort of meaty piece of work. I think just as a sort of caveat, I guess, it's kind of obvious, but sort of worth stating, I think. A lot of what we think we expect to see the impact of COVID isn't necessarily coming through yet in the data sources we've got access to. So a lot of the information that we'll have access to in terms of reliable, sort of cleansed data sources, there's always a bit of a time lag, usually sort of a year or two. So I think what we need to be cautious of and sort of keep an eye on over the next 12 months, 2 years, 3 years, is where we may start to see the impact of COVID start to appear in some of that data that we may not see today in a reflection in this JSNA. What we've tried to do to sort of fill that gap, I guess, to a certain extent, is where there are proxy measures that we can use, so whether that be local service data or whether that be qualitative insight or community insight that we can use to try and really understand that impact, we've incorporated that. But it's really just a sort of note really for the board to be aware of. Okay, thanks, John. So in terms of how we've got to this point today, so there have been some conversations with board members and a sort of a call out to get some data from across the system, and where we've had that back, that's been incorporated into the summary and into the detailed report. Thank you. So as I mentioned, we've tried to spend a bit of time looking at not just needs, but also some of the positive aspects, some of the areas where trends are heading in a good direction, and also some of the assets that we think are available across the county for us to make use of as a system in terms of how we sort of develop our strategies and our commissioning actions. So on the screen here, you can see some of the key headlines. So we continue to have a good rate of school readiness for children at the age of 5. Teenage conception rates continue to reduce and have in fact reduced by 25% in the last 3 years. We've got a low level of young people who aren't in education, employment or training. We've seen a reduction in our smoking rates in adults, and that's dropped by 3% since 2012, with a subsequent reduction in smoking-related deaths by 13%, which is now better than the national average. Death rates for under 75s for cardiovascular-related reasons, cancer and respiratory diseases have also dropped over the last few years. People aged 65 plus who are admitted to long-term residential or nursing care has fallen. And we've seen, although we saw a drop initially at the start of COVID for obvious reasons in the uptake and in fact the delivery of childhood immunisation programmes, we've now thankfully seen a return to pre-COVID levels in terms of the coverage and the uptake of childhood immunisations. Again, just thinking about some of the strengths and positive sort of news. So Richard mentioned that a lot of innovation and really sort of strong partnership working's happened over the past 18 months, and I think that's worth reflecting on. So the COVID-19 response in Staffordshire has been flagged continually as good practice and in fact best practice by Public Health England, via sort of nationally recognised awards systems and colleagues across the system. The whole system children's transformation approach to improve outcomes for children, taking a strengths-based culture and practice will lead to a good example of integrated education and social care teams, and that will be an innovative practice in place with the first in the country. There's nationally recognised initiatives around children and families, including Hungry Little Minds and family hubs. We've got earned autonomy status with the Supporting Families programme, which has meant that Staffordshire is able to work with partners to accelerate how early help is delivered. And the Supportive Communities programme, again, is just another example of that community-led approach, working with the public, with the voluntary sector, to give residents the information and tools they need to live healthy, independent lives. We're leading the way in dementia care with 2 centres of excellence built around the University of Stirling's gold standards for dementia care. And you've seen on Richard's presentation the high rate of sort of community action, so we capitalised and were able to sort of build on that momentum, and 60% of people had volunteered to help others within their community during the pandemic. I think as a note here, what we've sort of added a placeholder, because I think there's more that we need to and could be recognising and capturing here within this section. So I think this is a bit of a plea, I guess, out to members to say if there's more here that we could be adding in terms of what we should be recognising as some of the positive outcomes of the last sort of 12 to 18 months, then this is where we could include that. Again, this is just sort of a high-level overview of the kind of thing that we that will be in the sort of in-depth full JSNA, but it's just a way to sort of recognise some of those assets that already exist across the county, and some of those things that we can use as a system to help deliver those strategies, that commissioning activity, the activities that we need to put in place to try and help people improve their health and well-being. And this is just a small selection that was gathered with support of colleagues from the board. Okay, thanks, John. And similarly, these are some of the community assets that we know are available across the local area. And there are many, many more, and I think this is just something that we would hope to build on. So this is just an example of the kind of thing that we think can be in the JSNA as part of the assets and sort of strengths-based element. But I think this needs to be really built on, and again, it's an ask sort of for board members to come forward with any of the detail that could be provided to this section. And this is an example of the kind of activity that we can be capturing, some of the successes, I guess, from the COVID response via the Supportive Communities programme. So the launch of 18 community help points, funding for the community, a refreshed information, advice and guidance offer online, so people being able to access that support and help virtually where the face-to-face options weren't available, assistive technology tools to support people to remain independent within their homes. And as I've already mentioned, a really, really sort of significant increase in the number of people who are volunteering and coming forward to sort of help their own communities. Thanks, John. So that was a review of some of the positive stories, some of the strengths and the assets that we think can be built into the JSNA. This is an overview of some of the key issues and trends that probably need to be considered for the board in terms of informing key priority areas for action and indeed in developing the Health and Wellbeing Board strategy. So despite recent progress in lots of areas, the review has identified a number of key issues for Staffordshire. I don't think there will be any big surprises. There isn't any sort of significant change in terms of the type of issues that have been identified by previous JSNA or previously by the board in terms of priorities. But perhaps what COVID has done is sort of exacerbate some of those issues more and certainly exaggerate some of the inequalities that we've seen previously. So the wider determinants obviously is a bit of a kind of catch-all term, but in terms of things like older education and exclusions, housing, fuel poverty, so some of those key issues that I'll explore in a bit more detail in a second are consistently coming up as either sort of worse than the national average or worse than our statistical neighbours, so an area that we perhaps need to look at and think about how we respond to that collectively. Healthy lifestyle, certainly, again, so excess weight, both in children and adults, and levels of physical activity continue to be a concern. Mental well-being, again, previously has been identified by the board as a priority, but continues to be an issue that's cropping up and something that is certainly being highlighted by communities in some of the insight work that's been shared. Infant mortality, although is an improving trend, continues to be a concern. Aging well and the social care demand, and also dying well, so there are some concerns around some of those factors that I'll explore in a little bit more detail. And I think it's obvious, but it needs to be said that obviously the COVID impact on services and all those many outcomes consistently is coming forward as an issue that needs to be sort of addressed. So as I say, the summary will follow in a second, and then the annual data update will provide that full detailed view of all of these issues and the data behind it, and then there'll be an additional Year 1 COVID summary. Okay, thank you. So here you can just see an overview of some of the key trends. So as I mentioned previously, infant mortality has started to come down, but Staffordshire does still have the highest rate of the similar authorities, so its statistical neighbours. In a positive way, although there was a reduction in face-to-face health visitor appointments, antenatal health visitor appointments, should I say, during COVID, actually that's up to 68%, and new birth in-person visits have increased to 83%. Numbers of children in care do continue to increase, but children in need and those with child protection plans have reduced in the last 12 months, but there is quite a low level of Key Stage 4 educational attainment, with only 37% achieving that 9 to 5 pass in English and maths. In terms of Staffordshire and its as an environment, as a result of COVID-19, recorded crime did reduce by 15%, but obviously that data is slightly skewed by the fact that there was minimal sort of population level activity and sort of social movement, and we are seeing an increase in some of the reported cases of things like domestic abuse, and in fact referrals into domestic abuse services. So I think that there's a sort of a caveat behind that statistic that needs to be sort of explored a little bit. Fuel poverty has increased to 15% and is higher than the national average, but we do obviously have some real positive programs in place, like Staffordshire Warmer Homes, supporting homes with sort of green energy and warm homes. Thank you. Nationally and locally, there was an increase in unemployment due to COVID-19, yet we are seeing a continual reduction in that locally, and actually our rate now is currently at 3.9%. But again, I think, as Richard said, that needs to be observed with some caution, and there is obviously pockets of the population where employment is still relatively difficult, particularly in sort of younger people. As I've already mentioned, smoking rates continue to drop, which is really positive, and we're seeing GP-registered diabetes higher than the national, and that's a good news story because that means we're identifying people with diabetes earlier and therefore able to intervene with treatment earlier. Obesity-related hospital admissions continue to increase, and we now have around 2/3 of adults in Staffordshire with excess weight, as do alcohol-related hospital admissions, although there are some, again, caveats to that data in that it's a slightly unusual indicator, and so when you see the full data set, there are some additional sort of information which helps to provide a more holistic picture of where we're at with our sort of alcohol-related harm in the county. Local data and national data suggest a worsening of mental health for adults and in particular for young people. And actually we are seeing an increase in the suicide rate. And as I mentioned before, there's also some concern that we don't necessarily have a particularly good picture in terms of deaths occurring at home in Staffordshire. So we're lowest of all of our similar authorities, with only 21% of deaths occurring at home, compared to an England average of about 24.5%. Thanks, John. Just a really quick summary in terms of COVID impacts, and Richard's covered some of this already. As I've mentioned, I think we need to be cautious as some of the impact is continuing to unfold, and we won't necessarily see that in the data yet. But national research is starting to suggest that we're seeing a worsening of existing inequalities and increases in negative health outcomes for disadvantaged groups. We are, however, seeing an increase and sort of emphasis in the importance of local communities and that voluntary sort of approach in terms of providing assistance and support, which I think is a real positive. And there continues to be pressure on revenue streams and sort of particular sections of the economy. In Staffordshire, we know that there is likely to be a significant impact in terms of the missed early years of development on children and lost education time on attainment. And as I mentioned, we already have a challenge in terms of that key stage 4 attainment level. Mental health risks continue and have been exacerbated through COVID, as have child excess weight levels for various reasons, inactivity being one of them, but many and complex reasons for that. And as I've mentioned, unemployment does seem to be sort of reducing in Staffordshire, but we have a key issue in terms of youth unemployment, which is a focus. So that's a really quick sort of overview of what the data has sort of revealed, I guess. I suppose the questions to be posed to the board today are, how do we make sure this work is joint and strategic? So the joint strategic needs assessment, it needs to be more than just an assessment of the data. It needs to be something that's, as I said at the beginning, owned and shared and sort of collectively pulled together by members of the board. And then it needs to be useful and utilised in terms of informing our strategic direction. I guess it's a question about whether there's anything else across the system that we need to incorporate within the JSNA. Is there anything that's missing and needs to be considered? Are there any data gaps? And that leads into the sort of third question, which is, what else do you have as an organisation or as a partner or as an individual that could contribute to the JSNA and make it a more holistic and meaningful piece of work? So, you know, are there data sets that we haven't already had access to that might be able to be added to this to make it a bit more holistic? And then I guess the last question sort of segues into the next section around the Health and Wellbeing Board strategy, which is the sort of so what question. So we have an understanding of what the needs are and where our sort of priority areas might be for Staffordshire. What do we do about that, and how does that inform our development and refresh of the strategy? That's it from me, thank you.
Thank you, Claire. So do you want to take some comments or questions relating to the JSNA before you move on to the Joint Health and Wellbeing
I'm happy to
strategy?
do that if there are any specific ones, or equally I can just merge it into the next section if that makes more sense for everybody.
Okay, so are there any specific questions around the JSNA that's just been presented? Phil.
Thank you, Chair. Thanks, Claire, for that presentation. A couple of questions. I'm just wondering whether, A, we're confident we've got the balance between data and partner and community insight and intelligence right. So that would be one question. I suppose the other thing is as well, are we doing any predictive data analysis in terms of trying to not just look back at what we already know and where we are now, but also to get ahead of the curve and to potentially prevent some escalations or things that we think are going to get worse?
So I think the answer to the first question is probably no. I think we probably need to build in a bit more. So we have had some information from partners in terms of surveys that have been done, focus groups, things like that, but I think there's probably more out there that could be built in. So again, it's kind of an ask of everybody really. So if there is stuff that you think you've got access to that could be useful and would enhance the existing JSNA, and you'll know when you see the full version after the board what else is in there already, because there is a bit more around community input and community insight. There is some qualitative in there as well. But if you think there's gaps and you think you can help to fill those gaps, then absolutely, I think that needs to be incorporated. And in terms of the second point, I'm not sure that's necessarily what we'll get out of the JSNA, because obviously at some point it'll have to be published quite soon, and it's always immediately out of date once you publish it for obvious reasons. But I think that's the question about how we make it as useful as possible and how we use it as much as possible as a system. So I think we could get to that point, but that's very much dependent on the right data coming forward. So I think unless we've got that very specific data around, so a lot of it is a sort of rate, so rather than having a particular detailed understanding of a certain condition, obviously there has to be a relatively high-level overview of lots of things. I think to get down to that really sort of granular level of detail, that's probably the next step for what we do with an understanding of the sort of issues and how we then explore that in a bit more detail as a system to make sure we can do the predictive analytics, to make sure we can target the particular cohorts where we think there's an issue. And that would be my ask of, the work around population health management and things like that. So I think that's where the JSNA can feed into that work.
Thank you, Claire. Tim?
Again, thank you for the report. I thought it was really interesting. Clearly, within the JSNA, you're looking at county-wide statistics and analysis. But one of the areas of interest is around health inequalities. And is it part of the next stage, really, to look at those? Because I think clearly there's going to be inequalities both within districts and geographical areas and between them. And I think to gain an understanding of that and also related access to services, we'll need to get down to a deeper level to understand it and to take action to address it. Just keen to make sure that those inequalities aren't lost through the scale of data analysis at the county level. Thank you.
Yeah, and you're absolutely right. So yes, there will be some geographical sort of hotspot mapping within the full iteration that you'll see shortly. It may not get down to the sort of very, very localized detail that you perhaps refer to there, but I think that also is part of work that's being done around some of the other kind of data packs that are being produced and have already been produced, like the sort of PCN data packs and things like that. So I think some of that already exists and needs to be built upon, and I think some of it will be in the JSNA that you'll see come through. So I guess the question is, once you've had a chance to look through the geographical information and the inequalities information that's in there, if you don't think that's sufficient or you think there's more that we need to be exploring, then absolutely come back and we can do that. Yeah.
Thank you. Simon?
Yes, thank you. Simon Fogel from Healthwatch. Doing the JSNA is always a thankless task, I think, because there's always going to be some data you never come across. But once you've got to the point where it's like we think we've got as much as everybody can contribute, is there a plan to actually go out and say, this is what we believe is the picture, to actually ask the public if they've got anything to add? Because I'm sure people have different views. And whilst I know it's a huge data set, I think the art is trying to refine that down and pulling the key points out and actually going and asking that very question. And I think equally, as partners around the table, we could try and then get that out to our own networks and try and get that feedback to help make that pot richer.
John, can you respond to that, please?
Can I just check, Simon, do you mean public as in general? Yeah, I think there's a fair point in that, actually. We haven't really done that in the past, and probably there is a place for doing that. When we did the last Health and Wellbeing Board strategy, I do recall we worked with you to kind of inform that, but that was the strategy, not the JSNA. I think there's probably something about getting that information out in a public place and seeing what comes back, and seeing if what we state in there resonates with the public. So yeah, I think that's a good idea.
Thank you. So, if there aren't any other comments, if I could just summarise where we are with the JSNA then. So Claire, you've presented today and you're going to share with the members of the Health and Wellbeing Board those sections of the draft document for feedback, particularly looking for any gaps in data that we're aware of or some information from our organisations that you feel may be missing there. Could you give me, just sort of share with the board what the time frame is for that and when it will come back and be shared again?
I think, John, is a view to bring the completed version in December.
Yeah, we can make sure we can bring all of it back to the December board meeting. We can certainly try to circulate that before. I think there's a little bit more work to do on it, so I wouldn't want to commit completely to a really tight timescale, but we'll probably get something out. And we'll probably say it next in the strategy bit, but there is a workshop as well that we're talking about, so we can certainly bring something to that workshop around the strategy as well in October.
Okay, thank you.
So if I make sure when the full documentation comes out, if we'll include within that a contact email for people to provide their feedback and a sort of rough deadline for people to give that, so that we can work to the same time frame, if that's okay.
Yeah, I think that'll be helpful for everybody, especially you.
Yeah. Thank you.
Okay, thank you. So Claire, do you want to move on to the plans for the health and wellbeing
it's me again, isn't it?
strategy?
Okay. So obviously these two things are very much interrelated. One feeds into the other. Members of the board will recall that in June there was an agreement that it was probably timely to have a refresh of the Health and Wellbeing Board strategy. So even though you have a live document in place and a strategy that takes us till 2023, I think there was a view that because of the pandemic and the significant impact on the population and just how the landscape has changed quite dramatically, it was probably a good time to look at refreshing that strategy. So over the summer, there's been some work. John and I have met with various members of the board to sort of talk through what the strategy means to each of you, what you would hope to see within that, what your sort of key priorities might be, what the structure of the strategy might be, and I guess what it's used for from your point of view, what it's useful for and what it could be used for. We've also then reviewed sort of the outputs from the JSNA, as well as some of the sort of qualitative work that's happened. So there was a piece of research done with stakeholders over a couple of months, which explored a range of different issues. So those kind of things have all been sort of brought together to inform the proposal that I'm going to put forward today. I think what's important is when we talk about the Health and Wellbeing Board strategy, again, it's a statutory requirement to provide that strategic direction and that point of reference for all the members of the board. It can be relatively high level, so we can keep it nice and sort of brief, but it is about that agreement to take action on the sort of the key strategic priorities. So it doesn't have to be everything all at once, and in fact I think it's important that we prioritise and obviously agree where the efforts need to be focused. And it's about thinking about which priorities the board wants to focus on to have that real impact on people's lives and on people's health and well-being. So what you'll see in the pack today is a proposed structure for the strategy, sort of as it follows and based on what we've learned and from speaking to people and reviewing all of that information over the past couple of months. So we're proposing that there would be initially a sort of summary of that JSNA data effectively, so the key findings, what we've learned, the impact of COVID, and a specific section looking at those inequalities, what we knew already and whether they've been exacerbated and in which ways. Then a sort of quick review and summary of what feedback we've had from board members, so whether that be from the conversations we've had over the summer and the few meetings that we're still to have, whether that be from feedback we get directly from today, and also from the workshop that John's just talked about, which I'll cover in just a second. Health and wellbeing priorities. So the board has previously identified both obesity and mental health or mental well-being as priorities. So I guess it's a question about whether they still remain the top two priorities for the board, whether there are any others that we want to add. Repeatedly, we're sort of hearing back from people about the importance of taking a strength and assets-based approach. So this could be a section around sort of thinking about personal responsibility and independence, thinking about how we embed health across all of our policies and all of our commissioning decisions, looking at what support is available already within the communities and sort of accessible to people who are able to retain their independence and supporting them to do that, and also learning from good practice elsewhere, and thinking about that supportive communities sort of model, so how we make use of those assets within the communities already, so that the libraries, the community champions and all the knowledge and skills that's already accessible within the communities. And then looking ahead, so how do we take the strategy forward and make it a meaningful and useful piece of work? So there was feedback that people wanted it to be relatively light touch in terms of governance, but equally that the board is very much more focused on implementation of the strategy, and making that quite clear in terms of the ownership of it, and really making it a useful piece of work. There was feedback around how we make sure the board is well integrated with the development of the integrated care partnership, and that we avoid duplication but make it very clear how the two can work in synergy and sort of support and align, and having that joined up system. There was discussion about a shift away from services and sort of towards action on the wider determinants of health and prevention, so prevention which does have to include communities, and I think that was a sort of a golden thread throughout all of the conversations that we had. The timeline that we'd be proposing would be for today, obviously presenting this as a sort of suggested structure, throughout September to continue to have those conversations with board members to get some individual feedback, but also to have collective feedback come in from the board, with an initial draft being prepared by the end of September. We've then set up a workshop for the 12th of October, which should be in people's calendars, for a more detailed discussion on review of the JSNA and the draft strategy, and that would really then allow for that sort of rich discussion. And then between sort of September and December to have that engagement, further engagement with partners, wider partners outside of the board and the public, and then to have a final draft to bring to the board in December for any sort of final amendments, with a view to sort of publishing in the new year at some point. So that's kind of the proposed structure and timeline. I guess some of the questions that I would again pose to the board that came back from members that we spoke to over the summer, you know, from the data that we already have and that we've seen today and that you'll see over the next couple of weeks, what should be the key areas of focus for the board, and how do we frame that and how do we make it impactful? What one thing might you want from the new strategy, and what one thing would you want from the board once the strategy is in place? So I think it's just how we kind of convert that structure and those questions into the sort of next steps, whether this feels like the right sort of direction of travel, and whether colleagues have got any feedback at this point, and equally we can take feedback over the next few weeks and then follow that on with the discussion in October.
Thank you, Claire. Are there any questions or comments for Claire on what she's presented today? Tim?
Sorry, I forgot to introduce myself the first time round. So, Tim Clegg, I'm Chief Executive of Stafford Borough Council and Cannock Chase District Council. Just on page 11, I think it's section 4C, around health and wellbeing priorities, and you've quite rightly listed obesity and mental health. I wonder whether there's one around the support and advice available to members of the community to be able to take the right preventative measures themselves, and that might be through agencies and services, it might be through the voluntary community sector, or within communities, because I think we're quite good at telling people around lifestyle choices, but I wonder whether there are gaps or indeed assets to be built upon in terms of help and support for people who do want to make positive changes in their lifestyles. Thank you.
So, I mean, it wasn't necessarily a question, was it? It was more of a sort of a statement and a wondering, I guess. But I mean, I don't disagree, and I think that a lot of that is embedded, I think, and implicit within what we're talking about. But I guess it's a question for the board about whether that needs to be a standalone priority in terms of allowing people and sort of enabling people to be independent, I suppose. Is that, I guess, what you're saying? Yeah, okay, thank you.
Chair, I think it rather depends which way you cut the priorities. So that there's two ways it's typically done. One is to say that the priorities are the issues or the problems. So, for example, it could be mental health or obesity or whatever. The other way is saying that the priority is how we deal with them, which is information and advice and signposting in the voluntary sector, or the policies that we have that have an impact on health. We can perhaps try and contrive some sort of combination of the two. It's a bit like a grid, if you can imagine that, and to try and present that as a here are the issues and here's the thematic ways we respond and here's what we do in each space.
Thank you, Richard, for that. Simon Whitehouse has got his hands up on Teams, so can I bring Simon in now?
Thanks, Alison. Hopefully you can hear me.
Very loudly, actually.
Simon Whitehouse, ICS Director for Staffordshire and Stoke-on-Trent. I'll whisper into my microphone here. Claire, John, really helpful. I think in terms of how that's set out, in terms of the proposal, makes sense. Clearly, we would be supportive of making sure that we develop this in a way where we don't end up with duplication between the integrated care strategy that will need to be developed across the system, as well as the health and wellbeing strategy. So we would want to work to link them together about how does that then get delivered and how does that add value to the residents. And in terms of the health and wellbeing priorities, I think listening to the first bit of the conversation around the JSNA, whether that's around what we're going to do in terms of tackling the health inequality challenge that exists and what does that look like, or whether we're going to get into the frailty agenda, but also then the work to say, if we've got lots of priorities in lots of different places, then we end up skimming the surface on a lot, rather than actually being really clear on what are the 2 or 3 or 4 tops, I would suggest, main priorities that we bring a focus to, and then keep coming back to the question of, so what? And what are we actually going to do, and what does that mean in terms of making a difference for the local population that we've got responsibility for?
Yeah, absolutely. Thanks, Simon. And I think it's, as I was referring to before, it's the important thing is not just looking at what the issues are and what the sort of needs assessment tell us, but that question of how do we then prioritise and making some of those probably brave decisions about focusing our efforts. I mean, there'll be some things that we have to continue to do, and it is very difficult to obviously drop anything, and I don't think that's necessarily what we're suggesting, but I think that prioritisation across the system is really, really important, but it has to be meaningful. I think we've actually got, I had to move our meeting, so apologies for that, but I think we've got one in a week or two, so perhaps we can have a more detailed conversation about the ICS strategy and how we make sure that the two sort of align, and what sort of your planning and development process looks like, and the workshop we've got in October, and how we can make sure those two things knit together quite well.
Thank you.
Thanks.
Thank you. I think that's really important, isn't it, how this all sort of fits together, really, as we go forward into next year. Okay, so any other? Mark.
Yeah, so it's Mark Sutton, Cabinet Member at Staffordshire for Children and Young People. And I apologise for this, I don't have a particular comment to make on the JSNA, but can I just ask members of the board to speak directly into their mics, because the acoustics in here aren't particularly good. And I know members who are presenting and others like to turn around and look at the people, but when they do, I can't hear them.
Okay, thank you, Mark. It's actually it's quite difficult actually hearing, isn't it? Some colleagues. Thank you. We'll try better. Okay, so if there aren't any other questions or comments, so Claire is asking us to endorse the proposed structure for the revised Health and Wellbeing Board strategy, and also for members of the Health and Wellbeing Board to commit to supporting the further development and implementation of the Health and Wellbeing Board strategy. And as she's outlined, through feedback in conversations which are going to be planned over the next month or two, engaging with that and sharing with our organisations, being involved in the workshop, and feeding back as much as we can to support both the JSNA and the Health and Wellbeing Board strategy as it's developed. And the timeline is outlined. So as Claire mentioned, there is a date in the diary for the workshop to feedback on the JSNA and develop the Health and Wellbeing strategy on the 12th of October. And then the final draft will be brought to the Health and Wellbeing Board in December. Is there anything that you want to add to that, Claire? Have I missed anything?
I don't think so. I guess if anyone's got any issues or feedback or questions that they haven't been able to raise today, then either feel free to come to myself or John directly between now and the workshop in October. And then obviously we've still got a couple of meetings to have with board members that we couldn't fit in over the summer as well, so that will be an opportunity for those board members to speak to us. But anything else, you know where we are.
Okay, thank you very much. So, so I will take silence as assent to endorsing the proposed structure and committing to support the development of the Health and Wellbeing Board strategy. Okay, thank you. Okay, so if we could now move on to the next agenda item, which is, I'm going to bring Simon back in. So this is an update from the integrated care system development and also developing the relationship between the integrated care partnership and the Health and Wellbeing boards of Staffordshire and Stoke-on-Trent.
Thanks, Chair. So I'm assuming colleagues have the opportunity to read through the paper, so I don't intend to go through that in any detail. Hopefully the paper sets out main areas of focus in terms of the legislation that's happening in terms of the health and care bill that is currently going through Parliament, recognising that the bill contains many other areas of focus and work as well that this paper doesn't attempt to cover at all. This focuses on the integrated care partnership. We've touched on before the establishment of the integrated care system, which pretty much really looks at like the wrapper across all that encompasses the entirety of our health and care system. And then within that, we will have an integrated care partnership, which is a joint committee of equals between local authority and NHS, and the formation of the NHS Integrated Care Board. So clearly the NHS business aspects will be developed through the NHS Integrated Care Board, but we're really keen, as per the previous conversation with Claire and colleagues, to make sure that the Integrated Care Partnership, the development of that makes sense and is understood. I think it's clear to everybody that there is potential for overlap and duplication between the Integrated Care Partnership and the Health and Wellbeing boards. And of course, across the system in Staffordshire and Stoke-on-Trent, we have two Health and Wellbeing boards. And we want to make sure that we don't add unnecessary duplication or unnecessary work in, but really clear that there is a statutory responsibility to deliver the integrated care strategy and to have a focus of work around the integrated care partnership. So the first part of the paper sets out what's in the bill from a factual perspective, doesn't make any comment on that, really just talks about how that's set up and what the plan is within the legislation, should that receive royal assent. And then the second part of the paper from, so really section 11 onwards, then starts to talk about the work that's already taken place with system partners through the Integrated Care Board. So there's been a number of development sessions that have been held, and in section 11 of the paper, the principles and the main headlines that were ratified at the public board last week are set out from A through to G, really about making sure that this is a partnership, that it works inclusively, that it's got a focus on meeting as necessary, but not being overly burdensome in terms of governance, but as broad and encompassing and inclusive in terms of membership, and that it works through collaboration consensus rather than voting. So that's set out in the paper. Really, where we need to get to, I guess, going forwards is how do we define the relationship between health and wellbeing boards and the ICP? And partners of the ICP had a view that that would make sense to be done jointly with both health and wellbeing boards, so we don't end up with a fragmented approach in terms of that, and that we make sure we've got really strong engagement with the community and with the public, and that it's accountable. The work that it does is accountable to local communities. So there's a proposal in the paper for some form of joint development session, joint workshop between ICP partners and the two health and wellbeing boards to help shape what that work looks like, and how we can make sense of some of that duplication and some of the ambiguity, I think, that exists in the legislation around the way that this has been written and developed. So I don't intend to go through in any more detail, Chair, but happy to get into a conversation discussion, and would be useful to hear colleagues' views in how we take some of this work forwards to make sense of the legislation for the residents of Staffordshire and for Stoke-on-Trent.
Thank you, Simon. So if I could open it up to questions and comments and feedback to Simon, both on the paper and the development to date on the ICS, and also the proposal for joint workshop between the two health and wellbeing boards and the Integrated Care Partnership to explore this relationship and how we work going forward further. Richard.
Thank you, Chair. Yeah, I think a workshop would be a good idea. I think a useful prelude to that would be just a meeting of the two leaders of the local authorities, possibly the chairs of the two health and wellbeing boards and the NHS Integrated Care Board chair designate, just to confirm that there's a reasonable consensus about how the ICP should be designed and operated, and perhaps use that as a way of beginning to plan this workshop as well.
Simon, can I ask you to respond to that?
Yeah, I mean, in terms of working through how we best develop the workshop, I think that makes sense in terms of the chairs of the Health and Wellbeing Board. I mean, I think the local authority leaders and chief execs have been involved in the ICP development piece already anyway through their membership on the board, and so are cited on where this is at from my perspective. But absolutely having a smaller group to make sure that we get the best out of any form of development session or workforce or workshop makes an awful lot of sense.
Okay, thanks, Simon. So any other comments or questions? John?
Yeah, Alison, just quickly, we have put a placeholder in from the 12th of October, which you've mentioned a couple of times, so I'll just reiterate that, which is a possible date and time that we can use. If we need to flex that and do something different, we can do, but I just want to make that point really, so that's available.
Yeah, thanks, John. Unfortunately, the chair designate can't make that date, so from a ICP development workshop piece with the Health and Wellbeing Boards, we would need to revisit that date, unfortunately.
Okay, yeah. So we'll look at a different date, and also, John, you were proposing looking at the JSNA and the health and wellbeing strategy on that date as well. So we'd need to sort of split the workshop. Okay, so thank you. So in terms of the paper, we've been asked to discuss and agree a process to establish the relationships between the proposed Integrated Care Partnership and the Health and Wellbeing Boards, and the proposal was a joint workshop between the two Health and Wellbeing Boards of Staffordshire and Stoke-on-Trent, and representatives from the Integrated Care Partnership. So we will look at a date with that, with a pre-meet to think about how the form that workshop will take in order to get the most out of the most productive workshop that we can. Okay, thank you, Simon.
Thank you, Chair.
Okay. Oh, sorry, Tim.
Thank you, Chair. It's just a minor point, but I think we've had a really comprehensive paper from Simon here, and that's been really interesting. We've had a discussion over time about our priorities as a health and wellbeing board, but the two health and wellbeing boards haven't really shared their priorities or the work that they're engaged in. It might be helpful to have that in as some form of perhaps background papers. I assume that they're going to be very similar, albeit that the geographical areas we're looking at are different, but I think we need to have an understanding between all of the partners who are meeting at that workshop ahead of what all our priorities are. Thank you.
So, Chair, if you don't mind me coming back, because I think that from Tim's a really helpful suggestion. So almost some of the pre-work and the preps around giving people the information and the knowledge around where the two health and wellbeing boards are at, and then we would absolutely want to get into a conversation of, so what does that mean for the residents that we serve, and what does that look like then in terms of a work plan and the integrated care strategy that all partners will want to play into in terms of the production of that. So really comfortable with that suggestion from Tim.
Yeah, thanks, Tim. As you say, it's bringing it all together, isn't it? Thank you. Gary?
Gary Jones, Chief Exec Support, Staffordshire. Just a technicality, really. We're being asked to agree to a workshop. Has the Stoke Health and Wellbeing Board already agreed that, or when is the date that they will be asked? The same question.
So their health, so they haven't been asked yet, Gary. Their Health and Wellbeing Board is in 2 weeks' time, and we've asked for the same paper amended to be on Stoke-headed note paper to go to have the same conversation with the Stoke Health and Wellbeing Board at that meeting.
So yeah, that conversation is yet to take place, but yeah, we can feedback and as soon as we know when the workshop's going to be and the format it'll take, we will inform the Health and Wellbeing Board. Thank you. So thank you, Simon. So we now move on to the presentation and on the voluntary and community and social enterprise, which is going to be a dual show between Phil and Gary, and I believe, Phil, you're going to go first.
Thank you, Chair.
Thank you.
I think I forgot to introduce myself last time as well. So Phil Pusey, Chief Exec of Staffordshire Council of Voluntary Youth Services. You've had the presentation through looking at the opportunities and challenges of restart and recovery for the voluntary sector. What I've aimed to do is to try and provide a little bit of national context, bring it down to a local level, as well as providing a couple of case studies. So I'll whiz through the first few slides, which are just kind of for interest really around the national view on the importance of the charitable sector. The percentage of people who describe charities as essential or very important is beginning to rise after a recent dip during a period of some high-level scandals, shall we say, where particularly individual charities were focused on rather than maybe the broader picture. So, John, if you want to show that one. I think in terms of the importance, we've already heard from Richard in his presentation about the contribution of the sector locally to the COVID response, and also from Claire in terms of the importance of the sector in the JSNA and the response to that. The next slide is about trust and confidence, so a similar kind of measure where the trust and confidence in the sector is rising and in charities is rising. We haven't quite reached the level of doctors yet, as I'm sure the Chair would appreciate, but we are higher than one or two other public sector bodies and politicians. So I'll just leave that there before I get myself into any more hot water. The next slide is from a regular monthly report that is being done by the National Council of Voluntary Organisations, who are calling it the Respond, Recover, Reset report. They're looking at finance, service provision and the kind of people, the workforce in the sector, and reporting on a monthly basis on some of those changes. So I thought that would be interesting for the board to see that obviously there's a real mixture there in terms of organisations supporting a deteriorating financial position, a stable or an improving one, and also an increase or a decrease in the kinds of range of services that they provide, obviously very much related to COVID, where some have stepped up into new forms of work and new responses, whereas others have had to curtail what they do. Interestingly, a significant proportion are expecting a continual increase in demand over the next month, and that seems to be a stable position where people are anticipating increased demand. The workforce is not too unstable. There's a bit of a mix of decrease and increase, but not too bad. And I guess the main purpose of that is to just benchmark maybe some of the stuff I'll talk about locally with some national intelligence. I think what it may also highlight to you is the value that we have in Staffordshire of having both a generic infrastructure body like Support Staffordshire, who look after the whole sector, as well as a youth specialist infrastructure body of Skivis looking at the children and young people's sector. One report did arrive on my desk just after I submitted this report, which I thought might be worth commenting on, which is the Common Vision report around restoring social confidence. It's in my notes on the slide, so it may be something that people would want to check out. Social confidence is a term for collective societal feelings, so levels of faith and trust in each other, our community, public institutions, also levels of confidence in our place in society and our belief in our own personal agency to control and manage our own circumstances. Building blocks for social confidence would include that it's fueled by collective responsibility and duty, it's generated by strong trusted relationships, strengthened by community diversity, it's contingent to some extent on personal esteem and individual worth, it can be built through expression of both difficult and positive emotions, it can be strengthened when civil society has power and freedom, and it can be boosted via infrastructure or scaffold organisations, as well as being catalysed by an enabling state. So social confidence might be something that as a board and as a group of partners we might want to consider. So if we move on to the next slide, this data is from a survey that was completed by the County Council, who are currently starting the process of tendering the capacity building infrastructure contract that Gary and my organisations hold. So they went out to elected members from the council, council officers, as well as local voluntary organisations. And the feedback there covers the support most accessed. So 64% of organisations accessed funding and income generation support, similar number information, advice and guidance and training. Over half of the organisations access networking and almost half access safeguarding, including DBS support. The next slide talks about the future needs, so another question was asked around that, and organisations were very clear that the fundraising support was very much needed. Networking opportunities continue to be valued. Volunteer recruitment and retention support was going to be critical in the recovery and reset. Information, advice and guidance to an ever-changing environment was obviously also crucial. They also valued being able to, or having their activities promoted via a range of media so that communities and partners were aware of the good work they were doing. The sector is known for good work, but is not very well known for shouting about it. Interestingly, just as a footnote there, what the County Council values from the voluntary sector strategic partners include The youth offer, which enables the council to meet its statutory duties around sufficiency of youth services and the voice of young people. Programmes that address social isolation. I think that, as we've mentioned, the response, the recovery and restart around COVID has been valued. Partnership with the council in their communities principle, which includes early help, place-based supportive communities and digital inclusion as themes, and I'm sure Gary will touch a bit more on that in a few minutes. We also undertook a census of our membership during this year. This time we did it by telephone rather than sending out surveys to try and alleviate the pressure on organisations that are already stretched. So if you go on to the next slide, John, that would be helpful. Our census reveals that there's about 8,600 active volunteer roles being filled at the moment, and nearly 900 of those are filled by young people under the age of 18. That's a slight decrease on the previous year, but probably not as great a decrease as we'd feared in the current climate. Support requested by groups, again, echoes the council's survey, so very much safeguarding, including IAG training, etc., and training around other subjects as well, first aid, food safety, mental health and youth work. Funding support is critical, and that what they really valued was the signposting and connecting to relevant funders, but also support in writing bids and grant applications. The confidence of the sector, or certainly of our membership, was very high. 72% scored an 8 out of 10 or above in their confidence ratings. And when you compare that to the Charities Aid Foundation report, which suggests that 63% nationally have a high level of confidence in their future. The low confidence scores related particularly to securing venues that were going to be accessible and open to organisations. Obviously, a lot of venues have had to reduce their capacity, again, to allow time for clean down and all kinds of other things due to COVID. Volunteer capacity, a lot were worried about losing some of their long-standing volunteers, people not coming back after having a bit of a break, and, of course, funding. To bring it right down to earth, we've got a couple of case studies, one that Gary's organisation has provided, which kind of gets right down to the nitty-gritty of individual support. So this is basically a story of patient A, who's a middle-aged male living alone, shielding as clinically vulnerable, who was referred by a GP in the summer of 2020 to a social prescribing link worker. Obviously, this person was worked with over a period of time. They were linked with a buddy who, and actually, in a sense, formed or began to form this group. And it's clear that without the involvement of the link worker, both of the individuals involved in this case would have potentially been prescribed antidepressant medication, sent home. Without the group that they were involved in, they may well have remained isolated. Mental and physical well-being could have further deteriorated. Without that well-run group, the confidence to kind of open themselves up and involve others and get other people involved, we can easily imagine that they would have become regulars at a GP surgery, or worse still, become invisible until a real crisis hit and they were admitted to A&E. Instead of that, their mental health well-being has improved. They undertake regular physical activity. They have friends and a support network who look out for them and would notice their absence. And so although it's difficult to prove what would have happened if they hadn't been connected into this, this is a case of real change for the individuals and for the community that is around them. So moving on to a younger person's case study, and this might relate a little bit to Tim's comment earlier about encouraging people to look at what they can do to manage and self-care. A group of young people from our youth council have developed something called the Wellbeing and Health Action Map Plan, which is a series of sessions designed to help young people reflect and learn about their own emotional health and well-being. So they learn about the triggers, what can cause them to have a dip or to knock them off track, but they also identify the positive things that help to get them back on track and help to bring back a sense of well-being to them. The program can be delivered over a couple of sessions, or can also have other things enhanced into it, so the young people are developing things around the way that they look, around the way they engage with nature, and the program is continuing to evolve and develop. It was developed in partnership with a CAMS practitioner who had identified this as a program in America that could really help young people. So far, we've supported young people to deliver this in a number of settings: high schools, in national citizenship schemes, teams, to scout groups and other youth clubs. And the whole aim is that we encourage and support young people to deliver this to other young people, that every participant is then equipped to be able to pass this information on both formally and informally to their friends, so they can lead their own courses in their own schools or in their own settings. It's not a service, it's very much preventative and promotes self-care and builds resilience. It's open to all young people, so anybody can go. You don't have to have a diagnosis of any kind, and it's dynamic, so the young people will continue to develop it and evolve it in the weeks and months ahead. And just the next slide outlines some of the outcomes that we've seen already. They develop, young people who are involved develop character, resilience, confidence, leadership, and capability to manage their own well-being. If they're leading courses, they can develop presentation, communication, group work and evaluation and planning skills. Young people feel more valued, engaged and connected. They feel empowered and involved because it's their project and their program, and they experience a massive, making a positive difference to other people, higher levels of well-being, access to tools which can be applied to help and support themselves, and that they can pass on to their peers. So there's a couple of case studies locally that again may be of interest to the board. So in summary, the operational challenges facing the sector around restart and recovery are funding. That's immediate, medium-term and longer-term funding. Many organisations have survived by spending their reserves and will need a significant length of time to rebuild up that level of reserves to really make their organisations resilient for the longer term. Access to the right places and spaces to deliver from, to rebuild volunteer capacity, to enable organisations to access the right training and making sure it's affordable, to continue to provide up-to-date, robust information, advice and guidance, to promote awareness of the VCSC offer to communities and partners, and also to support them with a hybrid of digital and physical delivery. On a place-based level, I think we've already highlighted the inequalities that exist and obviously the challenges that they face in terms of the voluntary sector, both in terms of very often the groups that we would like to see in those places aren't able to be set up and established because the volunteer capacity isn't there, but also in terms of overwhelming need from those areas, particularly around those key areas that I mentioned: mental health, inactivity and isolation. And I think that's about it, Chair. So I think there were a couple of asks of the board on my paper, but I don't know if you want to cover them both together and go on to Gary's and then come back and deal with everything together.
Okay, thanks Phil. It was a really, really interesting update, and particularly hearing about those two case studies as well, just making it real. Okay, so is there anything in particular anybody wants to pick up from Phil before we move on to Gary? No? Okay, so over to you then, Gary.
Thank you, Chair. Just waiting for my slide deck to come up. Okay, thank you. So I think it's a really opportune moment to be having the conversation that I'm seeking to have today, very much because of what's happened over the last 18 months or so and where we're at now, which has been really well articulated there through Phil's presentation. Also because of where we're at with the development of structures and systems with our health system that we've already talked about today, and of course the refresh of the JSNA and the strategy that we've talked about today as well. So it's a really good time to be having this conversation. This is a piece of work I've been working particularly closely with Dr. Emma Hodges, who's Chief Exec of St Giles Hospice, upon. She unfortunately couldn't be here today, but I wanted to make sure that you're aware of that collaboration. So next slide, please, John. So these are the statements in the current health and wellbeing strategy, and although we're about to refresh that, I don't imagine that they will, there'll be a significant diversion from those statements, and that's because nobody could really disagree with them. They're good statements. But I think my question here is this enough as we look forward now to kind of turn the tide, really, against what we've again heard today of an ever-increasing demand, ever-increasing needs for services, and the ever-increasing costs that are associated with those, both for the health service and also for social care in particular. And I would argue that they're not good enough. They're definitely necessary, but they're not sufficient on their own, and that we must move beyond community engagement towards community empowerment. So what do I really mean by that? Because it's a term that kind of gets bandied around. Next slide, please, John. What needs to change? So we would argue that statutory bodies should be looking to move away from services that would be better served through self-help and community and voluntary sector support. That has to be managed. We're not looking for great swathes of cuts. We're certainly not inviting that or immediate withdrawal of services. And also that where their services are needed, that statutory sector services should try to remain community-based. They should try to be collaborative still and involve residents and focus on being that safety net. But what we don't want is, I don't think any of us want, is creating or growing or perpetuating or embedding dependency relationships where residents, customers, patients, whatever we want to term them, are seeing services time and time again, and it becomes habitual really because of that dependency. So what we would say is we should, at the same time as looking at reviewing whether those services are best delivered by the state, we should be trying to empower communities to address their own needs and use their own assets and actively avoid those services if and until it is genuinely appropriate for them to access them, because of course it will be genuinely appropriate in the right circumstances. Now again, many of you may say, well, this is nothing new, is it, what I'm saying really? We do have these kinds of approaches already. So next slide, John. And indeed, lots of really great stuff is happening in Staffordshire. There's lots of programmes, projects within the County Council, both children's services and adults and public health. Of a number of the brands there that I've represented on the slide, the place-based approach, supportive communities and others. Within the NHS, I would probably point particularly towards primary care-based social prescribing and other initiatives around primary care that's really making strides in this direction. Many of our district councils, all of them perhaps, will argue this is very much their ethos. I've just noted South Staffordshire there and their locality working model, probably because it's the best known and articulated, but I'm sure most of them would have equivalents. And the fire service would be a good example within the blue light services of their safe and well work that they do. We also hear in Staffordshire a lot about good practice from elsewhere, places like Froome, the Wigan Deal, and we're also linked in Staffordshire to New Local and their community power initiatives. But there are gaps in Staffordshire as well. I'm not wanting to sort of name and blame, but I would probably say that I'm certainly not as aware of this sort of stuff happening with perhaps the police And some of our NHS providers and commissioners, I think, could probably do better in this space as well. We could probably all do better, and I would include the voluntary sector within that as well. We're not always as empowering as we could be. And I also think in Staffordshire, we have a little bit of a tendency to be a bit deferential to other places and not always recognise our own expertise that we already have within the county. So I would ask us to be a kind of challenge on that regard. So lots of good stuff is happening in Staffordshire, but, next slide please. It's kind of confusing what we've got, and it's a bit fragmented, I would say. I would say we might not be using what are scarce resources as efficiently as they might be used. And given that this is about a collaborative, empowering approach with the public, with our residents, the fact that it's not as collaborative as it could be is a bit perverse, really, because it should be collaborative, and we could well be mystifying what is actually a similar goal by lots of different initiatives. It does have a kind of a whiff of initiative-itis about it, that we each keep reinventing things that are similar, but we make them different. Next slide, please. And the problem with that is this, that the public who we're really seeking to engage and empower, if they're confused by it, this is what they continue to see. You know, they will take a simplified view of the world, and they will see what we all know in this room is the NHS. That isn't a thing. You know, we don't have the NHS. There's lots of different components to the NHS, and I'm sure it's been many officers and councillors' frustrations in this room when you also get the council, when there is at least 3 layers of council within our patch, who have different approaches, different services, different accountabilities, different elections. So that can be frustrating, and it also tends to mean that it can remain quite transactional. So if we pay our taxes and we vote and you give us a service, please, rather than a more of a joint endeavour together. Next slide, please. So what I would be arguing for is a greater focus upon what our shared ambition is here, which I believe is articulated by those couple of statements or something close to them around a fully empowered community that's driving and delivering improvements for themselves in their own health and well-being, for themselves, for their family, for their neighbours, by implication for the wider community. And that our approach is co-produced with them, it's united, and it has clarity, it has purpose, and it has the confidence of stakeholders. Next slide, please. If we don't do that, we're going to continue, I think, to waste energy and waste time between us, valuable time and energy, and potentially lose the public as we go along. Now, within the approaches we've already got, that there are theories and change practices, transformation units and teams and change teams in many of the organisations that make up our health and care system, but they're tending to each operate with their own institutional change theories. And to some extent that's right, you know, we are a system, but we're a system that's made up of separate institutions, so they do have to do their own thing with their own teams, their own HR and staff and finances and accountabilities. But I would be asking for that to be a more united approach, a more united vision, and this was particularly one of Emma's challenges, I guess, to the system, is around how do we unite those systems. Next slide, please. So at this point, you're probably thinking, well, you might be thinking it's a load of rubbish, but if you're still with me, you might be thinking, okay, but this is all a bit all woolly. What do I really mean? What do we really want to happen here? There's 6 things, and I'll focus on the first 3, really, today. What we think is needed is a plan, really, a development plan that we all jointly agree on and we own to get us from where we are to where we need to be, from that engagement to genuine empowerment, because it's not going to just happen. Just because it's out there in communities doesn't mean it's completely spontaneous and it's going to happen without us doing something to encourage it and support it. So the first one is wide-scale system legitimacy for community-based approaches, by which we mean, what it says, full, genuine, total commitment from all partners, and in due course the ICP that's in development. And through that, we mean all members of all teams, of all organisations. There can't be ifs and buts and not sures and maybe or a little bit or yeah, but only 75%. And that doesn't mean I'm asking you today to nod and say, yes, I agree, because I think we probably need a more in-depth conversation about what does that really mean, because there are risks, there will be fears, there will be anxieties about what that really means. If we can get that, the second thing are those institutional change frameworks, so that when we go away from being a system-wide board back to our own organisations, it's implemented. And by that we mean plans that will mean changes in comm strategies, it will have implications for financial plans, it will have implications for clinical and professional kind of viability. And again, to make that really real, it's all very well if chief execs and senior teams agree with community-based approaches. If finance directors don't really believe it's going to solve their bottom line issue, and senior clinical staff in their heart of hearts still think maybe some drugs or some procedures might still be a better investment, then as much as we agree to it on paper or in public isn't really fundamentally going to change. So we need to address those concerns and talk through that financial and clinical viability. And then the third one that I've chosen to really highlight here is this evidence base. That there is a tendency for us to try and measure these new ways with the old tools and the old measures. Firstly, I would say that often just doesn't work because they're the wrong tools and the wrong measures. But I also think it's a little unfair for those who are trying to advance some of that new practice to have to take all of the responsibility for proving it, because that is in the face of, particularly in the NHS, this absolutely incessant system of monitoring and measurement that I'm sure you have some sympathy with, for the impact that has on those of you in the room. So there is something here about what the alternative evidence base might be for this kind of work in, and this is a national, dare I say, international issue, which isn't fully solved, but there are some ideas out there. Next slide. These would be 4, 5, and 6. I'm not going to talk through these in any detail, but you would then have to look at workforce-wide implementation. You have to look at the stability of existing activity, otherwise it's going to tend to be the stuff that gets cut if and when, or perhaps when, austerity comes to bite in the next few years. We've seen that time and time again in the past, again for understandable reasons, but we need to try and avoid doing that again. And also this thing around assurance, where does the assurance happen for things that are not individual statutory responsibilities, things that we have to do collectively together? I won't labour those points. So my ask today, the last slide please, John, is does this resonate with you? Is there some affinity with what I've said, or is it a load of nonsense, or does it make sense? Are you open to this challenge, to the status quo? Because that's what it is, really. It is saying we need to move away from how we've done things pre-COVID. And to that extent, I'm looking really for a kind of cross-sector group from all the different partners to go away and have a look at those first 3 actions and see where we're at place level as well, by which I mean district level in terms of perhaps local authority and also the places that our NHS system recognises. Because it may well be variable across the whole of the county. And to come back and report at a later date and feed some of this stuff into the emerging strategy as well, I think. So it'd be saying, to what extent do we think we have that system legitimacy for community-based approaches? Do we have the beginnings of those institutional change frameworks? Is there any similarity between them in different institutions, or are they all totally different? And are they conflicting even? And where are we with the idea of alternative evidence basis for this stuff? So I shall stop there. Thank you.
Thank you, Gary. That's really thought-provoking. So I'm going to open it up to questions and comments for Gary. Richard?
So thank you both for the presentations, really interesting. So I think in terms of the sort of questions from Gary, I think what you call the system legitimacy is already there, or at least people tell us it's already there. That is a whole variety of statutory organisations saying that in the future they want to encourage people to do more for themselves and to draw on resources in their community. I'm not so sure about the institutional change frameworks. I just a little concerned that we're overcomplicating this. I think there are people out there who need a bit of help, and there are people out there who want to offer a bit of help. There is a role for the state in connecting the two. Whether we need things like communication strategies, financial plans, all of that sort of stuff, I'm less sure. I just worry that it makes it more complex than it needs to be. I think what you may be looking for is the funding to support those people who offer help. And I think that's where the public sector and the voluntary sector, where there is the potential for a difference of views, frankly. The voluntary sector is of the view that the state should be providing a lot of financial support. The public sector typically struggles with that and can never offer as much as is wanted. And I think that's where we get into differences. Again, it's a fundamental thing is if you're struggling a bit, the first person you look to is your family, the next person is your neighbours. If your neighbours can't help, then you draw on some sort of voluntary sector organisation. Sometimes you'll be able to find it without any help. If you can't, then it's a trip down to your library. It's using a website, all of those sort of things. I mean, I think that's a fundamental operating model that everyone supports. It's how we convey that easily to the public, I think, and try and cut through some of the complexity that Gary alluded to. I definitely support taking this forward. I just want to try and make it simple, really, would be my response.
Thanks, Richard. Tim?
And again, thank you for the presentation. I thought it was very thought-provoking and really useful. I think the answer to the question, does it resonate with me, is yes. And I'm certainly up to looking at the challenge and giving some real thought to it. I think having been involved in providing kind of local government services for the last sort of quarter of a century, I think one of the mistakes that we've made up until very recently is about trying to do more and more for communities without necessarily asking always whether that is the right thing. And I think one of the consequences of that has been that it has at times disempowered communities who sometimes feel they now need to ask whether they can do stuff which actually would be much better done by them sometimes than institutions. I agree, I think, with Richard to an extent that I'm really comfortable with one. I'm not so sure about the institutional change frameworks, but I'm very much open to exploring those. I think what is implied in part by the process is a continual conversation and negotiation with communities about what organisations what statutory organisations are best doing, and where actually what we need to do is to step aside or to provide an enabling role because the community are better doing it themselves. And I'm sure you're not suggesting this, but I'm shy of an approach which says, well, we'll set down kind of in writing who does which bit. I think that is a process of negotiation, and I think that depends very much on the abilities of organisations in part to let go and communities to pick up that challenge. One of the things I've found working in community regeneration over quite a number of years is that often those communities that are perceived to have the greatest issues around deprivation actually often have the greatest strength in terms of community organisations and ability to do things for themselves. And I think as public organisations we need to take more notice of that and more trouble to find out about those organisations and to work with them on a much more equal footing than perhaps we have done to date. So I think really interesting presentation, and I'd very much be up for exploring how we might take that forward and learn actually as organisations about how we can be more effective, often by letting go. Thank you.
So if we, so in terms of the ask, Gary, it sounds like certainly I would agree that, you know, your presentation, it does resonate. It's how we take it forward, really. So the ask, you're asking for support to set up a task group of partners, and I just wonder whether this is something with the conversations we're having as an emerging sort of currently ICCS partnership board, and how that develops into the ICP, whether this should be something that that you take forward through that sort of development, really.
It could well be. Can I briefly come back on a couple of the comments?
Yeah.
Yeah. I guess it was sort of implied or suggested I might be overcomplicating something that's simple. I think I'd probably argue the reverse. I'm trying to simplify something that's actually really very complicated. It's not complicated as a concept, but it's complicated to implement out there because there's such a high level of variation in what the end outcome is. You know, in terms of the demographics and the communities and the geographies and the sizes and types of organisations or non-organisations. You know, we're talking very informal interaction here. I certainly didn't mean, in terms of a framework, that I'm trying to somehow suggest we ought to have a nailed down plan of exactly who does what in every community. I absolutely don't mean that. If I can take a kind of a fictional statutory organisation, it's okay if the chief exec says, yes, we want to work in this community-based way, but if that statutory organisation employs 500 people, how do we get from the position of that chief exec or council leader, or both, hopefully, committing to it, to every one of those 500 employees thinking about it and doing it in their day-to-day job? So I think what happens at the moment, there's a sort of an assumption that it will go from the leadership through the whole organisation by some kind of osmosis, rather than be systematically worked through the organisation. That's the kind of framework I'm looking. I'm saying, as an organisation, have you taken that top-level commitment and systematically applied it throughout your organisation in the same way that you might do with a safeguarding strategy, for example? You wouldn't just have the chief exec saying, we think safeguarding is really important, now we'll leave you all to it, thank you very much. You would work it through with training and one-to-ones and departmental or system strategies and plans. That's what I'm asking for. Every team, every department, every system, this should be coming onto their agenda somehow to make sure that they are empowered, enabled to do it, and challenged when they don't do it. So when they carry on defending their empire, that they, quite rightly perhaps defending from their point of view because they've been in service to the community for the last 40 years, when they're trying to carry on doing to rather than doing with, how is that challenged and tackled systematically within the organisation? I think at the moment it's kind of a blind eye is turned to it instead. So that's the kind of framework I'm looking for. And yes, I think it certainly would make sense to try and wrap this into the review of the strategy. It fits very well, I think, with the intentions that have been expressed, and also if we can link it into the ICP arrangement at the same time for consistency.
So I think just to try and summarise, I think if I could summarise and say that you're asking for us to support this as a direction of travel, to embed it into, as we work together on the strategy, and also as we work together collaboratively as a system to work towards the integrated care system, to recognise this as a way of thinking.
Yes,
okay.
And some volunteers, I think, to come alongside us. So, yeah, kind of got one, I think, from Tim there.
Okay, thank you. Okay, so if we can record the support for that way forward. Thank you. And just going back to Phil and your presentation, just like to again ask the board to recognise the presentation around the ongoing community and voluntary sector work, both in relation to the response to COVID, and actually as we go forward as we live with COVID into the future. Okay, right, thank you everybody. So if we now move on to agenda item which is for information, which is an update on the Staffordshire Better Care Fund. Oh, yes, she is. Yes. So, Roseanne, can I bring you in, please?
Sure, yeah. Hello.
Hi. Thank you.
So we've done a bit of a brief paper on the Better Care Fund because there was an update out a couple of weeks ago. So very, very briefly, we noted at the last board that there wasn't an update, so that we were kind of far into the year and we expected that there would not be much change to this year's plan, and that's very much what's come out. So the policy has been, we've had a publication that we will be expected to provide an update sometime in September, but what they've not specified is what that will be. So we've got a bit of an indication, and I've included an update in the paper. So we've got an update on the funding. We've now had confirmed that there'll be a 5.3% uplift across the CCG transfers, which we hadn't had at the last meeting. So table 1 confirms the funding, the CCG are in agreement. In terms of planning, though, for this year, so on the 19th of August, as predicted, they've published that there'll be a minimal change. There'll be a continued focus on improving how and when people are being discharged from hospital. And we're expecting to roll over a lot of the schemes, as I say, because we're most way through the year. But they are introducing some key metrics. So the joint BCF plan should focus on improvements on reducing length of stay, improving the proportion of people discharged home, using data on discharge. It's going to be quite difficult for us to get this performance metrics because we don't currently measure them like that. So we're going to have to do some work with our performance and with the CCGs to kind of put some thinking as to how we do that. So within the next couple of weeks, we should have more information. But because at this point, I don't have the specifics of what they're requiring the plan, I've recommended that again, it's delegated to the chairs, that once this plan's produced, I could share it with the chairs and that they could approve this virtually. And that's it in summary. So the recommendations are that if you would agree that the chairs could approve the BCF plan once we've produced it, simply because we haven't got the time to take it through the next Health and Wellbeing Board by the time that we've got the further clarity on what needs to be in it.
So before I ask if the Health and Wellbeing Board are happy to delegate that approval to the Health and Wellbeing Board chairs, is there any questions on the paper for Roseanne that anybody wants some clarity on? No? Okay, thank you. Okay, so we've been asked to note the paper and to delegate the approval of the 21-22 BCF plan to Johnny and myself as Health and Wellbeing Board co-chairs due to the short timescales which would not permit it to come back to the board for approval. So are you happy as a Health and Wellbeing Board to delegate that approval? Okay, thank you, Roseanne. That's been approved.
Great, thank you very much.
Okay, thank you. So
Thank you.
I look forward to receiving that.
Okay.
Thank you. Okay, and then if we now move on to an update on the Health and Wellbeing Board terms of reference. So if I could hand over to John just to give the context for this and why this has been brought today.
Yeah, it's very quick. The paper's in the pack anyway. The fundamental of it is just to advise people around the table that we've had to make some slight changes to terms of reference because the chair from the county council isn't actually a cabinet member now, he's a cabinet support member. So it's just really to reference that because it's been quite a little bit semantic and pedantic, I suppose, but it's just making sure that's noted really. Also to recognise that Julia Jessel, who's the cabinet member now, a cabinet lead for health and care, social care, is also now a member of this board. She's not here today, she's on holiday, but she will probably be at the next one, I'm sure. That's all it was really just to say.
Okay, thank you, John. So do we need to agree those changes to the terms of reference? So heads nodding, yes, okay. And there is a planned review annually of the terms of reference. I just wanted to just note that in terms of the proposed changes, if legislation goes through, is that there won't be clinical chairs of the CCG to co-chair the Health and Wellbeing Board. So I would suggest that we may need to think about bringing the terms of reference back to the Health and Wellbeing Board, maybe to the March meeting or certainly to the June meeting. So we may need to give some thought to that. Okay, thank you. So if we now just move on again for information to the forward plan, which is here for information, and I don't know whether, John, you want to highlight anything in particular from the forward plan?
Not really. Very briefly, there's a few things bubbling around. I think some of the discussions today will come back. I think the strategy and the JSNA. We'll need to look at commissioning intentions and how we approach that for the next board as well, I suspect. And there's a couple of other issues floating around which we might package as part of the strategy conversation around community champions, public health plan and obesity update, and probably mental health as well. We won't be able to fit all those in, so we'll have to have a conversation about that. Yeah,
okay, thank you. And again, noting that the obesity update was deferred from this meeting, so yeah, okay, right, thank you very much. So that brings us to the end of the agenda for today. So I'll thank everybody for attending and for their contributions, and bring the meeting to a close. And our next meeting is on Thursday, the 2nd of December, again in the council chambers. Okay, so thank you everybody.